If you are worried you have Lyme disease, or just like the outdoors, and want the peace of mind of knowing whether you have Lyme disease or not, there is a new Lyme screening test based on decades of research by Dr. Richard Marconi, a professor at VCU Medical Center. For more information, visit glymedx.com. That's glymedx.com, or email at info@glymedx.com.
Infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Robert, and welcome to today's podcast. This is a segment from the radio show that I had with Dr. Steven LaRosa, and he was reflecting on Lyme disease treatment, what he thinks and what he discovered, and hope you enjoy it. It's an interesting listen. One more blog post that I want to discuss before I let you go is about Lyme disease treatment. And Lyme disease is a topic that comes on my website quite a bit. In your blog, you write about some soul searching that you did concerning Lyme treatment. Can you tell us what you came up with?
Sure. So, as somebody who practices in a Lyme endemic area, would get called on and asked questions about treatment. And as your show has, so there's varying. It's a quite contentious area in terms of physicians who practice according to the IDSA, Infectious Disease Society of America guidelines, versus the ILADs or Lyme literate doctors, and a lot of it gets around duration of therapy. And unfortunately, I practice according to IDSA guidelines, which is usually a short course of therapy of 10 days to 14 days for an erythema migrans or early infection, and a month for Lyme arthritis. Up to a month for CNS infection, but I don't practice or am not according to what the Lyme literate doctors often will do in terms of prolonged therapy, because what we don't have as yet is definitive data that there is truly a persistent infection that requires prolonged therapy. In fact, the trials that have been done of prolonged therapy antibiotic therapy have not shown an improved benefit. And giving somebody prolonged antibiotics is not without its side effects. So, but the soul searching is, I wanted to dig down into the literature to see if there's something that I, should be thinking about, anything that's changed. The last Lyme IDSA guidelines, I believe, were published in 2006, and probably because of political reasons, it still hasn't, a revision still hasn't come out. But there are some things that I found, which is there is a school of thought that, at least in vitro, there's some data that maybe there's some other forms of Lyme disease outside the spirochetal form, so-called round forms or cystic forms and biofilms, and that these, at least in vitro forms, may not respond to the antibiotics that we typically use, like doxycycline or ceftriaxone or ceftriaxone, and that in fact they may respond better to agents such as daptomycin, which is an available IV antibiotic, or tinidazole. And it really got me thinking that what really needs to be done is probably more trials, that we're not done with clinical trials in Lyme disease. And if one is going to look to see if there's a potential that treating persistent forms makes a difference, that maybe the testing should be done with some of these agents that have activity against these other forms. So an initial maybe duration of therapy with doxycycline and cefuroxime, followed by one of these antibiotics that kill the persistent form. So I think there needs to be more work there. The other thing is that undoubtedly there are people who continue to suffer after they're treated, and a lot of people believe this is probably immune related. And there's some fascinating data that maybe it's not that there are actually live organisms present, but that the DNA from these organisms is still persistent, and that's what's triggering immune phenomena. And there's some data out of Texas Tech that if you gave an antimicrobial peptide that binds Borrelial Burgdorferized DNA and causes macrophages to engulf it, that you might have an improved outcome and you might limit these immune phenomena. So again, maybe we're just not doing the right clinical trials or haven't done all the clinical trials that we need to help these patients. And then the last thing is along the lines of diagnosis. We currently use a two-tiered diagnosis of an ELISA followed by Western blot, and sometimes these they lack sensitivity, and it's hard to tell the difference between old infection or somebody who's had a remote infection and a new infection. And there's some fascinating data that we actually can look at somebody's metabolomics, meaning the proteins that are released in their bloodstream, and that there's data that you can actually use a metabolomic signature of proteins that are released in the blood that can actually distinguish early Lyme disease. So I think we have work to do on the diagnostic side in clinical trials. So I guess the soul searching just resulted in the fact that we're not done yet, that there's still lots of questions that have to be answered.
No, that's a good way to put it. And I know in your article that you mentioned the use of stevia, and I've had Dr. Eva Sappy. She's been doing a lot of research on that on the show before. And you see any promise with that?
Well, it's stevia is obviously it's used as a nutritional artificial sweetener, but you're right. There's data about it having effects in vitro against these biofilm and round forms. Certainly is a compound that's generally regarded as safe, and so there's no reason that this couldn't be incorporated into a clinical trial to see if it has added benefits on outcome. I don't think it would necessarily supplant current therapy, but would be an additional adjunct. But in the setting of a clinical trial, I think we do have to be data-driven and evidence-based driven here. Unfortunately, in Lyme, there's a lot going on that's not necessarily evidence-based.
Yeah. Now, you did say that obviously you're in Massachusetts, so you are treating Lyme patients in your practice, and you said that you go by the IDSA guidelines. How successful is the treatment of these patients based on the IDSA guidelines?
Yeah, so we see a lot of what I'd like to say. The patients I see fall into a number of different groups. One is a lot of the people I see come with a clear, objective manifestation of Lyme disease. They have a Bell's palsy. They have an erythema migrans rash. They have heart block from cardiac involvement, and they have Lyme arthritis. And those people with a focal finding, that group, they tend to respond, I think, quite, and also Lyme meningitis. You see a fair amount of Lyme meningitis as well, with or without Bell's palsy. And those people, I think, respond quite well to the regimens according to the IDSA guidelines. And then there's the second group with people with a number of vague, let's say, symptoms, and who have been told that they have Lyme disease, and they've had a number of weeks and months of antibiotic treatment, and really are not feeling any better. And that's, if you read the literature, that's about 10% of people. I'm not convinced that they have persistent infection. I don't think there's data yet to support that. In vivo, in vitro, possibly, but not in vivo. Mm-hmm. And they've not gotten better despite recurrent courses of therapy. And that's a tough group because I believe that they're actually having symptoms.
Sure.
Many of those may be immune. And again, maybe they'll be in the future adaptable to other therapies. Those tend to be the main groups that I see.
Yeah, it's definitely a tough topic. I hear it from both sides pretty frequently.
Yes.
All right. Well, a very interesting discussion. I appreciate it. The website, again, is My Thoughts on the Future of Infectious Disease in Medicine. That can be found at drlarosa.blogspot.com. And I'll put the link up on the website. And I want to thank you, Dr. Steven LaRosa, for your time and expertise. I appreciate it.
My pleasure. Thanks for the time.
Okay.